Okay, recording in progress. Okay, I consent for this to be recorded. All right. I don't, honestly speaking, I don't really like speaking online because as a trainer, I like to be interacting with all my participants. However, I have learned from all these years from lockdown that eventually I will just take this as a podcast and I shall not attempt to make you type one or two and yes and no because it will never happen and it's going to cause a lot of awkward silences in between. So treat this as a podcast while you're driving or eating and listening to me on a radio or whatever. But if you do have any questions, I invite you to type it in the chat box. You don't need to wait for this to end to ask your questions or give me any feedback. As I present, I invite you to do so. However, I am unable to see all the questions and all that if I share my screen. I think that's the setback with Zoom is that the speaker is not able to see the chat box as they are sharing the screen. So I'll probably put about 10 minutes at the end of the presentation for me to read any questions that may arise. Okay, so I think everybody is good with that. I shall now present my slides. Okay, there you go. Jensen, my only ask from you now is if I freeze or internet drops, you don't hear me and stuff like that because I can't see you. So just unmute and say it, okay?
Okay.
Okay, thank you so much, Jensen. Alrighty, let's start and present. Okay, I just want to ask if you are able to see this, Jensen.
Yes, we see the screen clearly.
Okay, good. All right. Now we are going to start. Let me look at the time now. It's 1:33. Okay. The topic of our session today is hearing loss and also cognitive decline. I shall not get into the definition of a hearing loss because, of course, you know what it is. And as a supplement to what Jensen was saying to the introduction, I was born and raised in Kota Kinabalu, Sabah. I am still here in Kota Kinabalu, Sabah. I love this place and I had the option to stay in Australia, but I decided to come back to serve people here. I graduated with a Bachelor of Psychology at the University of South Australia. It was a twinning program. So I did 2 years in Health University College doing my psychology there, and then I proceeded to University of South Australia for a year to complete my Bachelor of Psychology. I took, I think, 2 or 3 months break before I continued to do my master in clinical audiology at Macquarie University, Sydney. I had the privilege to visit NAL, the National Acoustics Laboratory. I am also very privileged to have Harvey Dillon as my lecturer, but he didn't take it all. He just took few subjects which Professor Philip Newell was unable to do. I mean, of course, Professor Newell invited Harvey Dillon to take up some of the lectures. So, and the reason to why my path is a little bit weird compared to many of you Malaysian graduates is because I did not come from the science background. In school, I was the geography and the accounts girl. And the only path for me to become an audiologist was to do it as a master program and doing a bachelor in something. So I had an option to do Bachelor of Psychology, Bachelor of Speech and Hearing, or Bachelor in any science subjects. So I chose Bachelor of Psychology because, psych is something where we can use at every field in this world. So after I graduated, I came back and served my dad's company, Kinabalu Hearing Aid Center, which was established in 1994. So I came back, learned a little bit about the business for a year, before we sort of expanded the business. And that's when Ophelia Hearing Specialists came about. So this business has been around from 1994. So you do your own math. I think that's 30 years. And Ophelia Hearing has been around since 2010. So that would make Ophelia Hearing 14 years this year. So there you go. That's a little bit about myself. And I shall now dive into the topic of today. So this is a data which I plugged from the Department of Statistics Malaysia. The life expectancy for Malaysians in 2023 for both sexes is 75, male 72.5, and female, of course. This is a well-known fact that female live longer than males. We live up to an average of 77 years old. Globally, it's higher and about 80 to 85, but Malaysia is about 75 on average if we are looking at this. Okay, so I don't know whether they are speech therapists in this audience right now, but I'm assuming we do have. I will not go into the definitions of hearing loss because you know it. I'm not going to talk about the type and degree of hearing loss because also I'm assuming that you know it. But what I'd like to just define here is the peripheral auditory function and also the central auditory function. The peripheral auditory function is what we all know, that sound waves come from the outside, it goes into the middle ear, it vibrates, sends into the inner ear, and the inner ear converts these electrical pulses to be sent to the brain to be perceived as sound. So that's peripheral auditory function is the ability to detect the sound tested by pure tone audiometry, and that's the gold standard for audiology. Whereas for the central auditory function, it is beyond the inner ear. It is bringing the sound from the cochlea to be decoded by the brain. So this would be the ability for our brain to understand and make sense of the environmental sounds. So in basic term, removing all the jargon, how I tell my clients are, your ears are hearing okay, but your brains are not hearing okay. So that's how I differentiate peripheral and also central auditory and how I pass this information to my clients. Now, when we talk about cognition and cognitive decline, let's go into what we mean by cognition. What does it encompass? So cognition basically is a higher level function. It's a higher level function process in the brain. Things like attention, focus, memory, our knowledge, our decision-making, planning, reasoning, judgment, perception, comprehension, language, and visuospatial function is all part of cognition. So what does it mean by having a cognitive decline? It just simply means that there is a malfunction, there is an impairment in any parts of this domain as listed under the category of cognition. So does cognition decline? Now the question is, does cognition decline only happen to people of old age? Is this age-related, like age-related hearing loss? Or is this something which happens to people or children with ADHD, ASD, and other cognitive dysfunction, right? So that's a question for us to ask because papers out there are talking about cognitive decline, and a lot of these research are talking about the older population, the elderly population. So a lot of research is being done in the older population. The question is, so is it really age-related or is it an enchanted territory with other age group? Now, what does the research say about this area? So we're talking about this area, meaning hearing loss and also cognitive decline. So you'd see the word cognitive decline and cognitive deficit being used interchangeably, but the research in this area actually started way before, long time ago in Bethlehem, around the 1950s to the 1960s. Researchers has already began to explore the impact of sensory deficits, including hearing loss, on cognition function. What does this mean? What do they mean by this when they were starting to explore the impact of sensory deficit? It just simply means that they wanted to see whether hearing loss had any challenge or would it impact word recognition. So that was what they were trying to explore. So out of these, that's the reason to now why we have got speech recognition tests, because it was stemmed from here. So yeah, we all know that, of course, when you have a hearing loss, your speech recognition will definitely gonna deficit. So that's where it was stemmed from, the exploration of it. So for years and years and decades, they were looking into the relation between that, exploring, is there any or not? Where, as I was explaining about the umbrella of cognition, we've got plenty of it. Memory is just one of it. Understanding, processing, critical thinking is, very different from, there's so many various areas in cognition. So this was what was done. Cognition, as in the 1950s, was recognizing words and understanding speech because of hearing loss. And in the 90s, with this exploration, they were able to actually see that hearing impairment had a link with cognitive task. So for years and years, these researchers were exploring, you will see a lot of the word cognition coming up for decades and decades, until very recent in 2011 to 2013, when Dr. Lin and colleagues, Dr. Lin had a lot of research being done, and finally they were able to pinpoint this cognition function being dementia. So when we're talking about cognitive decline as a whole, we are still very much in the dark when we're talking about hearing loss in cognitive deficit. But specifically, the research or the light that is being shared right now is clearer in the realms of dementia. Okay, so that they finally saw the link that there's a risk of developing dementia if you have got a hearing loss. So what happened after that? The research in 2022, Gall also has a lot and lots of research that was done. And they finally say, you know what? Central auditory processing and also cognitive processing now is mashed up, it's blurred up. We are now unable to make a distinction between these two processes. Now it becomes very difficult. So audiologists know that there is an APD testing, an auditory processing disorder, you've got tests. Central auditory processing disorder, we've got tests. We've got all these tests that is being done to determine whether a person has an auditory processing disorder. Actually, in 2022, cited by Gall, there is already actually tests to investigate auditory cognitive challenges. However, this is not widely used in clinics, mostly done in research. Now the argument is whether or not we want to use it. How does this tool then able to tell us whether a person has an auditory central auditory function disorder or a cognitive processing disorder. So that's what Gall has been saying, and that's what they are saying in their research 2 years ago. Moving on to of a much more recent research last year, even they saw a strong relation between hearing loss and Alzheimer's disease. But again, there's a problem here. Previously, there was a blurred line between the two processing abilities. Now they're looking at what's the mechanism responsible for the links. It's still unknown. We don't know where exactly. Is it the brain shrinking? Is it because it's not used? What is it? We don't know the mechanism behind the link of hearing loss and Alzheimer's disease. 2023, Dr. Lin and colleagues, again, they found that that the higher the risk of dementia, the benefits of hearing aids was substantial. Now, the reason why I put a yellow pin here is because I wanted to highlight this research. This research done last year found that if a person goes through a risk assessment for dementia and they find that they have a high risk of dementia, the hearing aids will be able to slow down the rate of dementia by 50% and to at least delay dementia for about 5 years. So this is again, I'm trying to pull this out because you know how this world works, right? When a research comes out, there are opportunists in this world. So the opportunists where I see here will be the hearing aid manufacturers. So we don't want to have a risk of this information being twisted. We are not reversing dementia with hearing aids, nor can hearing aids guarantee that the person will not have dementia. So this is something which we, audiologists and also speech therapists, have to be very mindful that the research by Dr. Lin and colleagues is only if you have a high risk of dementia that you will be able to delay it with hearing aids. Okay, so please remember that, dear colleagues. Misinformation can happen. Manipulation of this information can also happen. All right, so knowing all these, bringing you, walk through from the earlier days to the current situation and the current research about hearing loss and also cognitive decline, and also how good hearing aids is to prevent dementia, the clinical implications. So what can we do as audiologists, with the information that is being given, is that we've got to stay in our line, guys. Although we know now that it is important for us to screen for cognitive decline, but remember that diagnostic cognitive testing and treatment are not within the scope of practice for audiologists and speech therapy. So I always remind this to younger audiologists, stay in your line, because we don't like people coming into our line too, right? So screening tools, there are a couple of screening tools, cognitive screening tools out there. But personally, I do not use a cognitive screening tool. But what I do is it becomes part of my case history taking. Things like, it's part of, do you have ringing in your ears? Do you have dizziness? What do you think about your memory? What is do you have any mobility issues and things like that? So I incorporate the question of cognition in part of my history taking. So I don't use a specific I don't use a specific cognitive screening tool. So that's how it works for me. Can work very differently from you. Again, this page or this part of sharing comes from my experience, my 14 years experience as an audiologist, and also being here in this part of the world in Sabah, where people may be a little bit different. Our culture is different. People are more receptive. I know people in Semenanjung can be a little bit pickier. You've got clients who want to pick a fight with you or who are sometimes smarter than you and stuff like that. So the experience that I have, you take it with a grain of salt. It may work in your line. It may not work in your line. Okay, so remember that we are not responsible to go so deep into cognitive testing and also treatment. When we do notice that our clients do have cognitive issues, like, a lot of my cases where I notice that their attention is not really good, they're focused, they look at you and they seem to have this glassy eye. They seem to not know what you're talking about. I usually would ask their family members if they have been brought to a geriatric specialist. And most of the time, people have not gone to see the old people doctor. So that's when I say, you probably need to also manage this problem with a geriatric specialist. Okay, so when we are able to identify this, our job is to refer out. Having said all the research that is out there, I'd like to also say that we don't need to wait for more research to establish a clearer link between hearing loss and also cognitive decline. The longer we wait, there's no use of wanting to wait for a clearer establishment between the link of hearing loss and cognitive decline. We already know that hearing aids are good to prevent dementia for high-risk groups. We already know this. But what is most important is the hearing aid amplification benefits overrides everything else. Socially, people have there's better social life. People hear better, communications become better. A lot of areas become better when a person is being amplified. Again, research is also saying that the world is actually underutilizing hearing aids as a tool for increase of quality of life. It is really underutilized, hearing aids. Also, knowing about hearing loss and also cognitive decline helps audiologists manage expectations about hearing aids. You know how we talk about REM? REM is the go-to tool for verification. We talked about the technology that comes with hearing aids in listening in noisy environment. But knowing and understanding that actually when REM is done and when the best technology comes from hearing aids, the question now is, did we take into consideration clients that may have cognitive decline? Because most of my clients who have cognitive decline, REM really doesn't really work for them. So when I do REM and say, okay, this is the gold standard for verification, this is going to help me, this is going to make this client X listen better in noisy environment. Or probably they are, I need to fine tune this, validate it with REM. But most of the time, friends, it doesn't work because they would come back and say, it's still very noisy. It's worse. Most of the time it becomes worse, and most of the time I end up fine-tuning it according to their comfort. So this is the thing about us knowing about cognitive decline and really comparing it with whatever that we're saying about REM and also the technology and listening in noisy environment. We also must take into consideration clients who have cognitive challenges. With the knowledge of us, because this is a multidisciplinary area, cognition, we work with the psychologists, with the geriatric doctors, with a lot of field when it comes to cognitive decline, is when we know better, we will not be promising the moon and the stars to our clients. And of course, we will be able to provide more care to our clients with cognitive challenges. So just giving an example of clients with cognitive difficulties, we need to have lots and lots of patience with them. I see them sometimes on a weekly basis. Those with memory problems would usually ask you the same questions over and over again. But I also like to share that one of the clients that I had was very smart, because he decided that one hearing aid were to be pink and one hearing aid were to be blue because it helped him remember better. So to date, he is my only client. He's an 80-year-old man that used the NIDA Sky pink hearing aid for the right, and the NIDA Sky turquoise for the blue. So it helps him remember. So this is some of the things where I don't come up with this, but sometimes your clients comes up with all these things, which we take and try to incorporate it with our future clients. So I think that's about it, my sharing. I can't see any questions right now, so I'm going to remove this screen so that I'm able to see you and see your questions. But before that, let me just... If you happen to see this QR code, I invite you to scan this QR code, because this is a really good paper. Easy to read, easy to follow. It's about hearing loss and cognition, what we know and where we need to go. Published in 2022. And it just gives an update of what is really happening with hearing loss and cognition. So there you go, ladies and gentlemen. It is now 2:00, and I shall hand over this mic back to Jensen. Over to you, Jensen.
Jensen has something to do. Sorry, so I'll
Okay.
thank you very much, Ophelia, for the informative sharing. And I like it that we don't stress our patient anymore by saying that if you don't wear the hearing aid, you will get dementia. Definitely that kind of thing. Last year I joined I took up a short course by the I think Viking Dementia Center from Australia. You don't have to pay, it's FOC, you all can Google and can try to attend, and you have to just answer question mini exam, and you will get a cert. The research also said that if you have hearing loss, there's higher risk of developing dementia, but they never emphasize that hearing loss equals to dementia. So it's very important for clinician not to overstress patient. We should be caring, and then once they having hearing loss already stressful enough, don't say that if you don't wear, then you will get dementia along the way. It's really stressful, very bad for them. That's why I agree from Ophelia's point of view. Anybody has any question?
Hello, Ophelia. Can you hear me? Hello.
Yes, I can hear you. But who's speaking?
Wilson from Here Care.
Oh, okay, because
Yeah.
the
I
green blinking thing.
think I sent one patient. This is kind of, I suspect this dementia to you last time.
Oh, yes.
Yeah. So that case, the patient after tuning, it keep on like forget about the solution we teach him. So this kind of patient, right? Normally, it's very difficult for audiologists alone to handle. That's why we need multidisciplinary come in to actually take care of the patient. Because I saw one dementia patient before during my practice, keep on forgetting where is he now, why he are doing the testing in the audio room. So even though the patient is brought by a family member, he's still complaining, why you brought me here, or what happened to me, what you trying to do. uh, that kind of patient, right? For my opinion, we need actually the family member to come in and help the patient to do the rehabilitation together with audiologists. It's take it like a child and then have a caretaker to actually do the hearing aid care and fit for the patients. Because we can't actually let go the patient without the hearing. It's very troublesome, especially they are easy to forget. So I think it's very important. We have to be creative enough. As you say, REM, it won't work for dementia case. So that's what we need to do lah. That's my opinion.
Thank you, Wilson, for your sharing. Yes, I've got to agree with you. Um, we don't be too worried about the dementia. I mean, with the research saying it's to prevent dementia. But what happens if a dementia patient works and comes into us, right? We've got to are we gonna misinform them by saying, hey, put this hearing aids on and it probably can make you better. The research out there is also saying that there is no cure to dementia. Medication, yes, to manage it, but it's irreversible. So audiologists also have to remember this. You don't overpromise our expectations. We have got to make sure that we set a right expectation to all our clients. Thank you again, Wilson. Is there anybody else would like to add anything else?
Hi, Basha here. I don't know if you can hear me.
Yes, I can, Basha.
Hi, Ophelia. I don't think we've met before.
No, I've only seen your picture on one of the, what do you call this, posters.
I have seen your picture too. So, well, now we can talk.
Yeah.
Well, just to add on to what have been said, the Achieve study in the US that looked over thousands of geriatric population who have hearing loss, and those who also have cognitive decline, not necessarily dementia, but MCI, mild cognitive impairment, if they are given, if they are fitted with hearing device appropriately, optimally, they find that in the first 3 years of usage of the device, 48% of the cognitive decline can be reversed. So while, yes, we don't want to be an alarmist, we don't want to be giving unwarranted panic and overburdening our patients who are just been diagnosed with hearing loss, it is very important to emphasize on the usage. Just like any other cases, we want them to retain the usage and we want them to come for follow-up, because those who already have MCI concurrent with hearing loss, if they do this in the beginning, it can stall the process. Yes, you're right. There's no cure for dementia, but it can stall the process so they have more years of quality life in them.
Yes, I don't know whether you came in a little bit later, Dr. Basha.
Yes, I did come a bit later.
Yeah. The stalling of the onset of dementia was 5 years. The research that I saw.
Oh, okay. So
it's-
that's even better rather than 3 years from the Achieve study.
yeah. So 5 years and accumulated like if it's like whole nation is like delaying it for 30 years or something like that. So it's quite 5 years is quite significant.
Yeah, definitely. Especially at that age, right? The age where you can spend more time with grandkids, with families, and all that.
Mm-hmm. Yeah, you're right.
Well, that's all I want to say. Thank you.
Thank you so much, Dr. Basha. Anybody else would like to chime in?
I come all the way from Klang.
Wow.
Yeah, I've got a job here in Penang, project going on. So whenever I come here, I drop by here.
Oh.
I don't do it in Klang.
Okay. If not, thank you, Ophelia, and thank you everybody for joining this session. I'm the one who fighting for lunchtime, and so please come and support lunchtime. Jensen wants to do it at night.
No,
Thank you, everyone. See
Can
you
we
again next week.
can we take a group photo, please?